And I think
Sir?
we are all good to go.
Sir, you are sharing your slides. Can you can carry on, sir.
Thank you very much indeed. So my brief today is to talk about hepatitis C elimination. Are we still on track? There have been a number of confounding factors. We're all far too well aware of the damage that COVID has done to our health systems, to our colleagues, to our friends. And I think it's right to have a look at where we are with the hepatitis C agenda. These are my conflicts of interest. And this is what we're going to talk about. I want to start by reviewing the new WHO targets for elimination. There's been a very significant shift in approach from the WHO, and I think it will be important for us to reflect on that and see how we incorporate that in our new drive to elimination. I think nowadays any talk has to talk about COVID. It's such an important issue and it has been so damaging and so destructive. So I'll say a little bit about COVID, what it's done to harm our programs, but also a little bit about the benefits. And I think COVID has changed the game a little bit and actually brought in some innovations that are helpful to us. So it's not all bad news. And then I want to finish with my thoughts on what next for Pakistan and how can we help you to eliminate. So let's begin by going to our friends and colleagues at the World Health Organization and their new guidelines. And these were issued just a few months ago. And I think they were issued in response to some very strong criticism. The early WHO targets, I think, were politically very attractive, being able to go to our government and say there is a target for an 80% reduction. And that sounds like a really impressive thing to do. But in the real world where you and I work, 80% reduction is impossible. What are we starting from? How many patients do we start from? What was the prevalence when the whistle was blown? Very few of us know that. And of course, the prevalence of hepatitis C is constantly changing. As people are infected, people are cured, people sadly die. So the target that initially was put forward by the WHO was, I think, targeted at our politicians. And perhaps that was a good place to start because they're the people who have to support us. But for you and I on the ground, it's impossible to show an 80% reduction when we don't know where we started from. So I think many of us have been very critical of the WHO and regarded their target as unworkable. They've listened, and I give them great credit for listening, and they've now issued new guidance. And I'm very pleased to say they're looking for pilot sites to assess the recommendations. So not only have they issued new guidelines and targets, but they've said they're prepared to look again and change things in the future. And I think that's very helpful because it means if we're doing the right things and finding it hard to prove we're doing the right things, WHO will help us and will change. So I think this is an opportunity. I think this is a very good step forward. So here are the guidelines. This is a very complicated slide. It's a very busy slide, and I'm going to simplify it immediately by taking out hepatitis B. And that's not, of course, because hepatitis B is not important, but today's focus is very much on hepatitis C. But I hope there'll be opportunities later on to talk about hepatitis B and perhaps consider how we achieve elimination of hepatitis B. So let's look at the chronic hepatitis C elimination issues. I'm going to start at the bottom because I'm going to start with the cheapest thing to do and probably the most important. Because the most important thing for me is to stop people getting infected. Treatment is fine, treatment is very effective, and treatment is very gratifying to us doctors. But actually stopping people getting infected in the first place is every bit as important. So the WHO targets are 0% unsafe injections, 100% blood safety, and exchange of needles and syringes for those who use drugs. There is, you'll be pleased to hear, a comment that says that in countries where injection drug use is not a major route of transmission, it's not necessary to evidence needle and syringe exchange. So I think probably Pakistan would qualify as one of those countries where injection drug use is not a massive contribution to the epidemic. I know that you have worked incredibly hard to achieve blood safety, and I congratulate you on those achievements. And I've been at many meetings where colleagues from Pakistan, with a great deal of pride, justifiable pride, have explained how blood safety is now becoming assured and how testing and registration is much more effective. So I think you are very likely to achieve blood safety, and that means you just have to make sure injections are safe. And here is probably the most sophisticated piece of equipment you need. And I really would advise a real drive within Pakistan to destroy needles used for injection. Lots of simple devices, you put a needle, you cut it in half, the needle's unusable. And I think if we're going to eliminate hepatitis C in Pakistan, we need to do the basics right. We need to make sure we are destroying needles. We're starting to introduce these more and more in our drug services in England to stop people reusing needles. I think in Pakistan, to have needle cutters more widely available, to encourage people to have single-use needles is going to be terribly important in the future. It's highly cost effective. It will save vast amounts of money on treatment. And I think that this is going to be probably one of the cornerstones of any elimination program. It's not sexy. You're not going to get an oral presentation at the American Liver Meeting talking about needle cutting, but actually it's important. The next set of guidelines are to reduce incidence and mortality. And here I think we have a problem because, again, it's a percentage reduction. And my own personal view is that this will change and the WHO will recognize that this may be an unachievable goal. But this is a very achievable goal because the WHO now recommend that we measure the incidence of hepatitis C in the general population and in people who inject drugs. And again, there's a caveat for countries where injection drug use is not a major concern. And there you simply have to show that the number of new people getting infected is less than 5 per 100,000. That is a very achievable goal. If you can achieve that, you know that you have treated enough people to slow the spread of hepatitis. You know that you are achieving elimination. You know that you will get rid of the virus in time from your communities, from your populations. So all you have to do is to test a large number of people and show you are not getting many new infections. This is an achievable goal. It's a measurable goal. And again, it's something that you can show to your politicians and drivers. Pakistan can measure, and Pakistan in many ways has led the world in measuring incidence. You can do this. To measure the incidence, the WHO recommends a test-retest approach. You take a group of people who test negative, you retest them 6 months, a year later. And I think that in Pakistan, elimination will require a retesting approach. That's not cheap. And one of my hopes from the COVID epidemic is that the vast amount of testing by PCR, the new innovations in testing, will reduce the cost of PCR tests for people with hepatitis C, and that will allow these sort of testing programs to go ahead. There are some ways to reduce the cost of large-scale testing. You can batch tests, test 24 samples by PCR in a single go. And obviously, if one is positive, then every single sample needs to be retested. But if they're all negative, you know those 24 people don't have hepatitis C. So there are new approaches to testing, batching, that I think will bring the cost down and make this a feasible approach. I think now is a good time to start thinking about how to introduce large-scale retesting. I turn once again to my Egyptian colleagues, and I have nothing but praise for the Egyptian hepatitis C program. They showed that in a developing country, it was possible to go out, screen people for hepatitis C, treat them all, and then here you can see they've done retesting. All those patients who were negative for hepatitis C were retested, and they were done in a case control fashion to show there was no reinfection. So this approach has been done. It is effective. And I think this is something that should be thought about now in Pakistan to put the structures in place to introduce it. I've talked a little bit about COVID and its impact, but I don't think we can minimize the impact of COVID. And I know many of you have suffered personally and seen friends and colleagues suffer from COVID. So this has hit us all and hit us all hard. Everywhere you look, COVID has reduced hepatitis C testing. This is data from America. It's published data showing a 60% fall in tests, a 40% reduction in prescriptions. I have to be honest and tell you that in my service in England at the height of the COVID pandemic, testing dropped by 90% and we had virtually no treatment for a period of several weeks. So COVID really has hit our services hard. But it's also changed things a little bit, and it's changed things for the better. A few years ago, we introduced a program of peers. Peers are people with lived experience of hepatitis C. They know about hepatitis C because they've had it and they've had treatment. And we got them to go around and encourage people to be tested and encourage people to be treated. And we introduced the peers in the networks in England at different times. And here's the data that we've published and presented, looking at the number of people who start treatment. If you have peers, people with lived experience of hepatitis C, traveling around, talking to people, encouraging them to get tested, encouraging them to get treated, we saw a 12% increase in the number of people treated. That's a huge increase in treatment. It wasn't just people who use drugs, interestingly. Having somebody talk to you about hepatitis and say, I've had it, I had the treatment, this is what you do, increases the number of people who have treatment. And during COVID, we used the peers to deliver testing kits, to deliver drugs, to encourage people to attend. And we now have in England a program of several hundred peers helping patients access treatment. I'm a big fan of peers. I have to be honest and say when it started, I didn't really see the value. I thought I talked nicely to patients. I thought they trusted me and that would be enough, but it isn't. So what we've discovered is that using volunteers, and we don't pay the peers, we give them vouchers for travel and a little bit of money for tea and coffee, but they do this as volunteers. And it's been a huge impact on the number of people coming forward for treatment. So I do think this is an answer to everything because peers help. We've also seen changes in the way we monitor treatment. We used to spend a lot of time doing blood tests on people before treatment, during treatment, after treatment. We kept them coming to clinics every 4 weeks. But actually, we've discovered we don't need to do that. What we found in COVID is that telephoning patients is every bit as good as seeing patients. We now talk about min-mon treatment, minimal monitoring. See the patient, exclude cirrhosis, start treatment, see them again for SVR12. Minimizing contact, minimizing travel, and improving outcomes. We've moved in my practice to telephone clinics. 80% of my patients are now seen by telephone. We book online so the patient can attend the hospital at their convenience, have a blood test. I can access the blood test on my computer. I phone the patient, tell them everything's fine. They don't need to come to hospital. They just need to answer the telephone. And we started sending tablets by post. Why do we need patients to come to hospital to pick up a tablet? Why don't we send them in the post? And it works. So what we've discovered in COVID is that sometimes you can do more by doing less. Now, of course, these approaches are not going to work everywhere. I think in rural Pakistan, posting tablets is not going to work, but in the city centres, perhaps it will work. Perhaps less monitoring of treatment will encourage more people to come through. Telephone clinics won't work for everyone, but if just 30–40% of your patients can be managed without being seen, then that reduces the burden, reduces the travel, makes it easier to get treatment and easier to eliminate. So I think COVID has shown us that there are different ways of doing things, perhaps better ways of doing things. And I think that's been helpful as we drive towards elimination. So for Pakistan, where do we go next? I said before that Pakistan has led the way, and I do believe that the house-to-house surveillance in Pakistan that was introduced really very early on was the first good example of how to assess the burden of disease. I think that's really important because you know where you're starting from, and that gives you a very good position to begin. There are some splendid examples, and many of you and many of my colleagues have been involved in outreach programs, going out into village communities, testing and treating people, and they're working extremely well. Clearly, we need to do more, but you know how to do elimination. You have the models. And I think a big step forward has been the change to core antigen testing. This is a paper published very recently looking at core antigen, showing that it's every bit as good as PCR. It's not quite as sensitive. You miss a tiny number of people. By and large, core antigen testing is good enough, and it's a lot cheaper, a lot easier to do. So I would encourage you to think about the need for expensive PCRs when perhaps you can use something a little cheaper. Treating to eliminate is clearly the way forward. We don't have a vaccine yet. I think it would be very unlikely that a vaccine will occur over the next few years. Jake Liang published an article very recently in the New England Journal talking about the need to do trials by infecting people with hepatitis C to find a vaccine. Not sure that's going to be very popular, and I'm not sure a vaccine is going to come anytime soon. We've got a lot of pan-genotypic drugs that we can use that are highly effective, and we know that these will work to eliminate. And of course, soft DAC is the most affordable. The data we have on soft DAC comes from India, comes from the Punjab, and shows that soft DAC is good enough. Here's the SVR data from Demon's paper. Large numbers of people, 50,000 people, excellent response rates. So soft DAC, Mr. Chairman, is good enough. Is it good enough for everyone? Is it good enough for all strains of hepatitis C? Genotype 3b may be a little more resistant to soft. Is it good enough for cirrhosis? What are the SVR rates? There are still some big questions that we need to answer, and we need to answer these in Pakistan because they're the questions that are relevant to you. So I'm pleased to say we're starting. I'm working with excellent colleagues, Saeed Hamid, Saad Niaz, Huma Qureshi and Asad Chowdhury, looking at a Wellcome Trust funded study to address these questions and try to find out whether what we're doing in Pakistan is enough or whether we need to do a little more. Do we need to give a little soft bell for some patients? Are there subgroups of patients who need slightly different treatments? We need answers so that we can drive towards elimination. And over the next few years, I'm sure Saeed and his colleagues are going to be presenting to you the data from the study. And I hope that will begin to answer these important questions. So to summarize, Mr. Chairman, elimination in Pakistan is very possible. And I think you have led the way in testing. You've set up treatment programs that work, and you've shown that they work and published on them, which is fantastic news. Egypt has set the stage for a national program and demonstrated that you can scale up local programs, you can do it nationally. The tools are now available, and we will need progress now to accelerate and reach these goals that you have set. So, Mr. Chairman, it is always a pleasure to meet my colleagues from Pakistan. I thank you for your attention, and I'm really grateful for the invitation. And I do hope that